Thanks so much, Evan, and it's really nice to be here with all of you virtually. Perhaps not as we imagined 6 months ago or 9 months ago or last year, but nonetheless happy to see 131 of you on the call, and it's being recorded for those who can't make it. I'm just so excited to start the fall off with what is one of the most important parts of Ariadne, which is our community, as Evan talked about. This community of fellow innovators, seekers, strivers, change makers, do-gooders, good doers, and generally people who don't accept the status quo as is. And want to approach design, testing, and scaling interventions with the thoughtful, human-centered, rigorous, and impactful way. So I think that the last 6 months, if they've been anything like they've been for me, for you, have probably been unbelievable in so many ways. And I think that that makes our mission, which is stated here, really quite profound and important and clear. We really want to save lives and reduce suffering through the production and testing of these scalable solutions. At both critical moments in people's healthcare journeys, and we've really, since our founding, focused a lot on these moments like childbirth and the moment before you have a surgery and the moment that you need to have a conversation about your serious illness journey, but also think about moments as a set of critical system junctures that we need to really think about and innovate around, like visualizing the performance of childbirth systems and primary healthcare systems, and understanding the impact that can be had when you make what formerly has been invisible more visible throughout our healthcare improvement journey together. So in the next slide, I think that we can all also agree that COVID-19 has exposed and magnified so many of the known gaps in healthcare systems, whether they be gaps in our inability to merge public health and healthcare, our inability to be prepared for pandemics, our continuing and unacceptable disparities in care, access, outcomes by racial and ethnic groups, as well as location, race, space, and place matter evermore, and force us all to more deeply reconsider what we are doing in our daily work to be impactful. COVID-19, like any organization, COVID-19 has forced and demanded of Ariadne that we quickly not just pivot, which is the word du jour, but really think carefully and quickly about what is our most impactful moment and what is our most impactful set of skills that we can bring to what is a global effort. I started the day off this morning on a call welcoming participants from 15 countries to what's called the Joint Learning Network, a network of country leaders in health policy and planning stakeholders that our primary healthcare team leads, a set of seminars, as well as the surgery team too, on infection control practices and really spreading those practices. And what emerges so quickly is the fact that we are in some ways so united by the problems that confront us. We are so divided by politics and ineffectual leadership on national levels, and leadership that denies science and denies facts, and that pushes people apart and pushes communities apart and disparages communities, especially people of color. And yet we are also united by a network of thoughtful, inventive, pragmatic implementers all over the world that are bridging the gaps left by their leadership to still work together to improve health outcomes. I mean, some of you may have seen yesterday in the Gates Foundation Goalkeepers report that we've basically wiped out 25 years of global health progress in maternal and child health, vaccination coverage, access to primary health care in less than 25 weeks with COVID-19. And yet, as sobering and depressing as that is, the nidus for how we build back better and how we build back different is there. And it's there in this community of 142 people now online, and in the communities that we are privileged to participate in order to really drive change in our healthcare system. I want to give you in the next slide just a quick sense of what we've done, often with you, during these last 6 months. We've really started initially in early March around really asking the questions and putting out evidence-based material. What can individuals do in their communities to reduce the risk and spread of COVID-19? So a huge focus on social distancing, a huge focus on mitigation responses what groups of individuals can do in terms of wearing face masks, in terms of what now almost seems trite. Like we know the playbook, masks and contact tracing, but that playbook wasn't always clear. And I think we're happy that we contributed to that sort of call to arms with a lot of work in media, a lot of work. Thank you to our comms team, and thank you to really all the teams across Ariadne that help mobilize that sort of playbook. How do you go grocery shopping? Which masks do you wear? How do you socially distance? What is social distancing? How is that? How do you stay socially connected while remaining physically apart? How do you maintain resilience in this new bizarre space that we find ourselves? We then quickly moved to thinking about the healthcare environment, to thinking about ORs and how to reduce elective surgeries and how to keep infection rates low in hospital and clinic settings, how to move to telemedicine, how to move to virtual care, how to think about the new obstetrics pathways, and how to basically protect health workers to live and help another day. And from there, we've moved more broadly to thinking and working with organizations, businesses, communities, schools. We've done a lot of work on thinking thoughtfully about school reopening, about working with nursing homes and other elder care resources, in working across communities and business, private-public partnerships around how we can kind of take this false dichotomy of health versus wealth, business versus public health, and say, actually, we're all in this together, and we all need to build together and be thoughtful together. And finally, in these last couple of months and in the next few months, we're doing a lot of work led by Rebecca Weintraub, by Catherine Semrau, by so many others, around what our next layers of country level and global responses can and should be, especially around vaccination. Not that we know which vaccine we have or will use, but rather how we already now, without knowing the specifics of any potential usable, effective vaccine, how do we start thinking about vaccine delivery and distribution along gradients of equity, along gradients of allocation, who gets it first, second, third, and fourth, along gradients of verification. How do we know, especially in countries like the United States, how do we know on a local, state, and national level who's gotten a vaccine? And how do we maintain the production capacity, especially as it seems that we'll need probably more than one vaccine and probably more than one dose of multiple vaccines. So there are all sorts of thorny, complex and important issues that we've tried to apply our basic playbook, our way of being and doing. We've produced a lot of tools and resources. You can see them on the website. I'm really particularly happy to say that this has been a democratized process, meaning this hasn't been 5 people always writing, always going on TV or doing blog posts, but really we've had participation from over 40 members of Ariadne. That's nearly half of Ariadne, and so many of you in our community in building and writing. And we've had wonderful participation from Harvard Medical School students and HSPH practicum students, and so many friends from near and far. So that's been a little bit of our response, but really that response in the next slide is keyed in on our playbook. And our playbook and our way of knowing is thinking, what are the gaps to close? What are the gaps between what we know we probably should do and what actually happens? And that's been actually pretty hard in the case of a pandemic in which we're only 9 or 10 months into our existing contact with this 15 gene virus that just appeared. And so what that's forced us to do in a good way is think about all of our partnerships and all of our friends and family near and far who are closing these no-do gaps, and how we highlight their best practices, such as what we did with our colleagues in South Korea, who quickly stemmed the tide of the pandemic and had so much to teach us, and in fact had a playbook out of the Korean CDC that they were willing to share, and with an amazing set of again, friends and family, Ariadne, not Ariadne, all in this together, translated the multi-100-page Korean CDC infection control guidelines into English within a week and a half, and then into Italian at the request of the Italian government, because it was the height of the Italian spikes, and really made meaningful differences in hospital and district and regional level changes in policy. Again, by suffusing that knowledge, by closing a no-do gap where someone somewhere knows and others do, how can we bridge that gap so that we can close and do better for the thousands of diagnoses and thousands of procedures and drugs and all the complexity of our healthcare system. And in the next slide, it's with the reliance on this approach to human-centered design, and so much credit goes to our innovation teams and innovation leader Grace Galvin and Evan Benjamin and all of the folks who participated in really prototyping, again, over 35 different types of tools that we've developed with and for so many different partners, and kudos to so many of the program teams, like the delivery decisions team, who partnered with hospitals in New York City and design partners at Mass Design to think through on the fly how to redesign entire units for hospitals in the midst of the pandemic. And now we're moving also into that test phase with some of our key tools, like with our school reopening guides, testing them iteratively and actively with partners in 8 school districts across Massachusetts, and working with our communications teams and our program teams and our platform teams to spread the learnings and areas of effectiveness that are working for both COVID-19 and also for our other work. And in the next slide, many of you ask what the year ahead for Ariadne looks like. And it looks like both a focus on this new normal with COVID-19, but also maintaining our incredibly laser-like focus on these key steps, these key parts of the healthcare journey that our teams have built evidence-based tools and spread useful ideas and shown impact from birth to death and everywhere in between. But really this focus on birth, primary care, acute hospitalization and surgery and end-of-life care, and you know, a whole expanse of wonderful products and projects, from seeing where we are with the Better Birth trial results, and important paper out this week on the relationship between adherence to the number of practices in the checklist and outcomes. Incredible work with the Delivery Decisions Initiative on the next step of testing and starting to socially franchise their team birth model to improve outcomes and dignity during childbirth, with an eye on reducing unconscionable inequity in maternal mortality across the US. Huge focus by the primary healthcare teams on maintaining the ability to understand primary healthcare system performance, even in the face of COVID, and spreading that data visualization tool to up to 30 countries by the end of the year, despite COVID. Continued work by the Better Evidence team to spread evidence-based, effective digital clinical tools, not only to over 22,000 practitioners all across low resource settings in the world, but also through a new exciting partnership with a number of African medical schools to start embedding the use of evidence-based clinical decision tools early on in the cascade of training. Incredible work with the surgical teams on both understanding post-surgical outcomes through digital tools like Health Prism, spreading team training and OR crisis work, and as well as in hospitalization, exciting work with Rural Hospital at Home led by David Levine. And finally, in end-of-life care, exciting expansion of the serious illness communication work, exciting work to really understand through learning collaboratives, formal as well as deep embedded systems work in particular health systems, how to train the majority of clinicians, whether in primary care or hospital medicine or oncology, in the use of these effective communication tools. In the next slide, it's clear before, during, and after George Floyd's murder that we have to reckon with our unconscionable inequities in the US. And as Martin Luther King said, some of the most unconscionable inequities are those that happen within the healthcare system or through the healthcare system. We have maintained a focus before on equity, especially in our childbirth work, Cities Project, as well as Boston Foundation work, understanding upstream drivers of maternal mortality inequities, and a huge focus on inequities in so much of our global childbirth and global primary health care, and also our domestic serious illness work. But so much more needs to be done. And what you'll see and what we're planning for is really a deeper focus in the intersection of equity and healthcare systems improvement. And if that's an area that you're passionate about, we want to hear from you and with you and join us in that work. And we want to learn from your work. In the next slide, we also are going to see more explicit work, and this ties into what Evan said today with International Patient Safety Day, more explicit focus, especially as we're so excited to welcome formally Dr. Mary Brindle as the head of our Safe Systems and Safe Surgery team, really focusing on new areas of safety, really doubling down on safety as a key outcome throughout the healthcare cascade that we're going to do more explicit work on. And so look for that. And again, if that's a field that you're interested in, we want to hear from you. Looking ahead in the next slide, we're going to take even a wider aperture and use this enormous destabilizing event of COVID-19, which has shown in glaring relief so many of the inequities and dysfunctions of our fragmented healthcare system, to try to really start now to reimagine together with as wide a view and wide a group of people as possible, including really suffusing patients and families and their voices in a convergent set of simple principles that I think we can all start to agree on, that our healthcare system needs to be rebalanced between primary specialty and hospital care, that it needs to have a more integrated focus and workflow with public health, that payment systems need to support the delivery of patient-centered care as opposed to be their own idiosyncratic drivers of inequitable care, and other areas. So look to be part of a conversation that we hope to catalyze around how we can reimagine healthcare systems of the future, both in the US and abroad, and hear more voices and convene more voices and broadcast those to the halls of power in this coming incredibly important year. And in the next slide, also think, and this is some new work for us, about what are the financing and organizational models that will be needed to support better care delivery, as opposed to what are the care delivery models that need to fit into broken financing and broken organization models. So that's a big area of, I think, exciting focus, writing, convening that you'll hear. And in the last minute, I just want to talk about in the next slide, two new initiatives that are really, they're not getting started, they're getting amplified. I told you a little bit about the Better Evidence digital clinical resources and really exciting work across the training and practice perspective in so many countries. And that work is being led by Julie Rosenberg and Rebecca Weintraub, as well as rural home hospital work led by David Levine. Both of these actually started as Spark grants. They've now made it through the Spark grant cycle and found funding and found really impact. The rural home hospital is taking the successful Brigham Home Hospital program, applying it to rural Utah, as well as the Blackfeet Native American nation in northern Montana and central Pennsylvania as well. And so we're really excited to be launching these. And finally, in the last slide, you'll be hearing a lot more from us and from leaders like Rebecca Weintraub and Catherine Semrau around our work, thinking through with a set of incredible partners how we can already start to prepare for the coming delivery challenges for both delivering accessible testing, and you may have read a Tools article last week. If you haven't, we can chat that in. Launching a testing alliance to merge and meet testing needs with excess lab capacity. It's called the Assurance Testing Alliance. And then finally, really thinking about vaccination and vaccine delivery and who will do it, how it will be done, and how it will be done equitably. Those are things that you can expect to hear more from us, and we'd love to learn with you. So with that, I've gone over a few minutes. I'm sorry about that, but we've got a lot going on at Ariadne, so it's hard to fit into some small timetables, but I'll turn it back to you, Evan, and really appreciate you all being here.